Hello, and welcome to my video presentation for NURS-FPX4030, Making Evidence-Based Decisions. My name is Rebecca Vela. The topic of this video is remote collaboration and evidence-based care. In this video, I will discuss the care plan for Caitlin Bergen, a pediatric patient with a new complex diagnosis as provided by the Capella University Vela Health Scenario. I will discuss an evidence-based care plan to improve outcomes for Caitlin and describe the practice model used in its development. I will reflect on the evidence acquired and discuss interdisciplinary collaboration related to her care. Caitlin Bergen is a 2-year-old female admitted to the pediatric unit at Valley City Regional Hospital for pneumonia. This is her second admission for pneumonia in 6 months. She presented with respiratory distress, thick secretions, adventitious breath sounds, and fever. She has a medical history of meconium ileus at birth, and she is up to date on most vaccinations, excluding influenza and HAV. Her mother states that when she kisses Caitlin, she tastes salty. The provider notes some decrease in subcutaneous tissue and suspects malabsorption of nutrients. Through history and workup, Caitlin is newly diagnosed with cystic fibrosis. Caitlin and her parents, Janice and Doug Bergen, who are currently separated, live in a rural community about an hour away from the nearest hospital in the small town of McHenry, North Dakota. Both parents report working long hours, so Caitlin's daily caregiver is unclear. Caitlin's care team at Valley City consists of her physician, Dr. Erica Copeland, pediatric nurse Virginia Anderson, respiratory therapist Rebecca Helgo, and social worker Marta Simmons. In McHenry, her primary physician is Dr. Walter Benjamin and social worker Madeline Becker. While Dr. Benjamin is familiar with cystic fibrosis, Caitlin will be his first patient with this diagnosis. As the team prepares for Caitlin to discharge to home, the team must collaborate to develop an interdisciplinary care plan. Coordination between the Bergens, Valley City, and Dr. Benjamin is crucial to Caitlin's health and safety, particularly during the winter months when a drive to the hospital may be treacherous. The Bergens must develop the skills needed to perform Caitlin's chest physiotherapy, provide adequate nutrition, obtain and administer medications and supplements, and understand how to access available resources. Dr. Copeland orders several evidence-based treatments, including chest physiotherapy, nebulized breathing treatments, pancreatic enzymes, fat-soluble vitamins, and a high-protein, calorie-dense diet, and Dornase alpha, all of which are recommended by the Cystic Fibrosis Foundation's Infant Care Guidelines in their Infant Care Clinical Care Guidelines. Dr. Copeland and Dr. Benjamin have established rapport and communication preferences, with Dr. Copeland available to Dr. Benjamin as needed for consultation or recommendations after discharge. The Bergens must continue Caitlin's chest physiotherapy at home. Literature shows that the learning curve can be steep, leaving parents feeling doubtful and anxious as infants rely on others for airway clearance. Andrews et al., 2020. Rebecca Helgo, Caitlin's respiratory therapist, will be available after hours to Skype with the Bergens as needed for education, evaluation, and video assessment. Chest physiotherapy can become a burdensome task for caregivers and should be scheduled as part of the day so that the time and crew does not overwhelm the family. As Caitlin ages, she will begin learning blowing games and exercises until she can do huff breaths independently. Primary care will continue with Dr. Benjamin. However, current literature shows that an interdisciplinary telehealth care model for pediatric patients with cystic fibrosis is an effective means of treatment. NURS et al., 2021. The telehealth care model is comprised of asynchronous visits with different disciplines via telephone or audio-video spread throughout the week at mutually agreeable times. The Bergens are separated from one another, work long hours, and are located rurally, so this is an excellent option to accommodate their family. Additionally, telehealth will save the Bergens time driving to and from distant appointments and the costs associated with transportation. Consideration should be made to include additional members, which are standard practices in cystic fibrosis centers, NURS et al., 2021. As Caitlin ages, she may be met with unique physical or developmental challenges, best assessed and treated by a physical therapist. consultation of a registered dietitian to address Caitlin's nutritional deficiencies, and educate the family on dietary practices for a growing infant would also be appropriate. According to Gardner et al., treatment adherence is often suboptimal due to its complexity and time requirements. Targeted reinforcement and follow-up combined with formal interdisciplinary team discussions improve adherence to treatment plans and patient outcomes. By providing frequent education and support by multiple team members, physician, nurse, respiratory therapist, dietitian, therapist, educator, social worker, etc., the Bergens will better understand the disease and its treatment and are more likely to exhibit positive coping mechanisms and adhere to treatment guidelines. All team members must follow a person-centered approach in developing Caitlin's treatment regimens. Clinicians should discuss the treatment burden at regular intervals with the Bergens and assess for difficulties in balancing cystic fibrosis treatment with life responsibilities such as children, other children in the home, family issues, and work. Andrews et al., 2020. Additional information on Doug and Janice Bergen's coping skills, personal behaviors, financial means, and plans with each other would be beneficial in developing a long-term developmental plan for Caitlin. I most closely followed the Johns Hopkins evidence-based practice model in developing this care plan. This model is ideal for enhancing team collaboration and identifying best practices, Center for Evidence-Based Practice. The steps of the Johns Hopkins model are dynamic and resemble a PDSA cycle or the nursing process. Initially, I asked what resources would be needed and from what teams when Caitlin is discharged home. This question follows the first step of inquiry, leading to a practice question. Next, I reviewed the peer-reviewed literature published in the last 5 years in scholarly journals and reputable websites related to cystic fibrosis, infant care with cystic fibrosis, pediatric cystic fibrosis, remote interdisciplinary collaboration, and evidence-based practice models. Evidence collection is the next step in the model. After reviewing multiple sources, the most relevant evidence was translated into the creation of Caitlin's care plan. Similar standards of care and recommendations were noted across the literature. Crisis prevention through multidisciplinary team and family involvement was the most reoccurring theme for children with cystic fibrosis. During the COVID-19 pandemic, these children were rapidly forced into using telehealth and virtual services. NURS et al., 2021. As horrific as the pandemic has been, COVID rapidly opened new doors for patients with healthcare access challenges. While it's not a substitute for in-person assessment, supplementation with remote visits has proven to be adequate and, in some instances, more beneficial than in-person visits. When children are at home in a comfortable environment, clinicians often gather more reliable behavioral data than in a doctor's office. Gardner et al., 2017. The final step in the Johns Hopkins evidence-based practice model is evaluation. Evaluation of outcomes will be evident in Caitlin's healthcare record. How often has she been treated for respiratory compromise? Are her medications being filled on time? Are her parents participating with the care team? Are her growth and development appropriate considering her chronic illness? The most relevant and useful resource I found regarding Caitlin's care plan is the article by Enak et al., 2021. This article is peer-reviewed, published in a telemedicine journal, and only a year old. It described the necessary components of an interdisciplinary team for pediatric cystic fibrosis and presented a successful telehealth model used during the recent pandemic. It explained the steps taken to build redundancy in the systems and improve communication. Following the application of numerous PDSA cycles, consistent clinical workflow and patient satisfaction was reported. The methods used in this model translate to many other primary or specialty facets in healthcare. My rationale for choosing this article is that the model presented applies to multiple fields beyond cystic fibrosis, creating a personal interest in its information. Additionally, it was relevant and specific to the Vila Health scenario. The data presented is credible and, though specific, easily translatable to other areas without deviation from the model. Interdisciplinary collaboration is an essential component of coordinating patient care. Many disciplines must coordinate to provide care and family education for optimal outcomes in a child with cystic fibrosis. As previously discussed, a team consists of physicians, nurses, respiratory therapists, dietitians, social workers, physical therapists, physiotherapists, educators, and more. According to Gardner et al., 2017, the team should participate in structured, regularly scheduled formal care discussions to reflect as a group, assess patient outcomes and treatment adherence, and provide objective feedback. Redundancy in patient education and strategy from multiple disciplines results in better patient understanding and compliance. Anox et al., 2021. The Bergens live in a small rural town with limited resources, and most of their routine care will be provided remotely. While this presents a challenge, this is far easier than in years past with today's technology. Video calls via Skype, Zoom, or FaceTime are available on most mobile phones or small, inexpensive tablets. For people without internet access, many public places have free Wi-Fi. The financial burden of remote visits is also less than in person. With the Bergens' long working hours, remote visits can be made to accommodate their schedules without missing work. The interdisciplinary team can meet via web conference or conference call to discuss Caitlin's care plan, reducing the team members' burden for transportation time and cost. With the availability of electronic medical records, clinicians can view Caitlin's data with relative ease. The use of these current technologies mitigates the challenge of distance collaboration. The same methods and models applied to cystic fibrosis centers readily translate to other specialties in future care situations. Care teams can discuss multiple patients within the context of one web, telephone, or video conference instead of numerous individual interactions. Additionally, by meeting remotely, more team members should be present and available for meetings as their location is at their discretion. In conclusion, telehealth will be an extraordinary tool in caring for Caitlin. Caitlin's care plan is created using evidence-based sources to identify appropriate interventions and interdisciplinary team members. Her care continuum is improved with Dr. Benjamin's coordination with the Valley City Regional Hospital's team. Through remote collaboration, Caitlin's parents will receive the education, resources, and support required to meet her needs. Thank you.